All right, let's get right into it. Today, we're tackling a massive topic for your board exams, whether it's USMLE or PLAB, extravascular hemolysis. We're going to crack the code on how red blood cells get targeted and destroyed, and more importantly, how you can spot the clues on exam day.
You gotta understand, this isn't just random. It's a targeted takedown, a hit job. And to solve this thing, you have to think like a detective. What's making these red blood cells vulnerable? Let's find out.
So, where does this all go down? Well, the main stage, the primary battlefield, is the spleen. If you want to understand extravascular hemolysis, you have to know the layout of this kill zone.
Extravascular. It's just a fancy way of saying outside the blood vessel. The spleen, it's basically acting like a super sophisticated and kind of deadly quality control filter. And just lying in wait inside that filter are the executioners, these specialized cells called macrophages. They are ready to pounce on and just eat any red blood cell that isn't absolutely perfect.
Now this is where it gets really interesting because the macrophages have a hit list. They're not just killing at random. In hereditary spherocytosis, the cells are just too stiff and round to squeeze through the spleen's tight corners. With sickle cell, those crescent-shaped cells cause a literal traffic jam. And then you have warm autoimmune hemolytic anemia, where the body's own antibodies slap a kick-me sign, an IgG tag on the cell, marking it for death.
Okay, knowing the theory, that's step one. But applying it to a clinical case, when the clock is ticking, that's how you nail the question and bank those points. So let's step into the clinic and solve a real mystery. And just a quick but important reminder before we dive in, all this content is for educational purposes only. It is not, and I repeat not, a substitute for professional medical advice. Always consult with a qualified professional for any clinical decisions.
So here's our case. A 20-year-old walks in. They've got jaundice, and you can feel an enlarged spleen. You look at the blood smear, and bam, you see these classic spherocytes, these small, perfectly round red cells with no pale center. Then the labs come back and they show a high MCHC. All that means is the hemoglobin is super concentrated inside these tiny cells. So, what in the world is going on?
Listen, if you remember one thing from this entire explainer, make it this. Seeing spherocytes is a huge clue. Yes, but it's a classic board exam trap to just jump straight to a diagnosis like hereditary spherocytosis. You've spotted the pattern, but you have not found the cause. Not yet.
So, if seeing a spherocyte isn't the final answer, what is it? Well, that pattern points us to two prime suspects. Your job, as the clinician, is to figure out which one is the real killer.
Okay, so how do we unmask the true culprit? We need an interrogation tool, a definitive test that can break this case wide open and tell us exactly who to blame. And that tool is the Coombs test. And this slide just lays it out perfectly. It's an inside job versus an outside job. On one side, you have hereditary spherocytosis, an internal genetic problem. The cell membrane is just born weak. The enemy is in the family tree. On the other side, you have warm AIHA. This is an external attack. The body's own immune system becomes the enemy, with antibodies literally taking bites out of the red cell membrane, forcing it into that sphere shape. So, in any exam question that gives you a patient with signs of hemolysis and spherocytes on the smear, your brain should immediately go to one critical question. What is my next best step?
And the answer is always the direct Coombs test. I want you to think of this test as a forensic analysis. It dusts the red blood cells for fingerprints. Are there any antibodies, any evidence left behind by the immune system marking these cells for death?
The Coombs test result is your fork in the road. It's that simple. If the test comes back negative, no antibodies found. That means it's an intrinsic problem with the cell itself. Diagnosis: hereditary spherocytosis. But if that test comes back positive, you've got your culprit. It's definitive proof of an immune attack. Diagnosis: warm autoimmune hemolytic anemia.
So why do these spherocytes actually die in the spleen? It all comes down to flexibility. A normal healthy red blood cell is like a gymnast. It's super flexible. It can bend and squeeze through the tiny passages in the spleen. But a spherocyte, whether it's from a genetic defect or an immune attack, it's rigid. It's like a block of wood. It gets to those splenic cords, tries to squeeze through, and just gets stuck. And that's when that macrophage that's been waiting moves in for the kill.
All right, let's lock this logic in tight. We're going to do a quick rapid-fire drill to burn these associations into your memory for exam day. You ready?
You see that triad in a question stem. where does your mind go instantly?
Exactly. Hereditary spherocytosis. The problem is baked into the cell itself.
Okay, next one. What if that Coombs test lights up positive?
That's right, warm autoimmune hemolytic anemia, driven by IgG antibodies. The immune system's the bad guy here.
And what about the jaundice? Remember our patient was yellow? What type of bilirubin is causing that in hemolysis?
Yes, indirect or unconjugated bilirubin. The rapid breakdown of red cells just completely overwhelms the liver's ability to process it all, so this unconjugated form builds up in the blood, and that's what makes the patient jaundiced.
Okay, now for a super high-yield bonus tip. This is a huge trap on exams. You have a sickle cell patient who suddenly gets way more anemic. Is it an aplastic crisis or a splenic sequestration crisis? The key, the absolute key, is to check the reticulocyte count. Those are the baby red blood cells. If that count is low, like near 0, it means the bone marrow factory has shut down. That's an aplastic crisis, usually from parvovirus B19. But if the RIC count is high, the factory is working overtime, but the spleen is stealing and trapping all the cells. That's a splenic rubbery, or a sequestration crisis. Knowing that difference is pure gold.
So, there you have it. You've now mastered the logic of extravascular hemolysis. You can spot the pattern, find the suspects, use the Coombs test to convict the culprit, and you know exactly why the spleen is the execution ground. But this is only half the story. What happens when the war isn't contained to the spleen? What happens when it moves inside the blood vessels themselves?
When red blood cells are literally blown apart by the complement system, the situation gets even more dangerous, and the clues you look for are completely different. To be truly ready for your boards, you have to master this second battlefield. Join us for the next explainer, where we dive headfirst into intravascular hemolysis and the complement war. You don't want to miss it.